Andrew and I were planning on running a multi-day state-of-the-art workshop, which would have been one of the, which would have been fantastically exciting for trainee microbiologists, infectious diseases physicians, pharmacists, and unfortunately, it's not the worst thing that COVID has caused this year, but it was a bit disappointing for us that we couldn't necessarily run it in all its glory. But one of the key aspects that we were hoping to be able to run was to have this next session, which has two of the real leaders in the world, and I'll let Andrew introduce them. But it's an absolute pleasure to be able to sit and listen to the wisdom that comes from them and that follows the wisdom from Professor Lavigne. So I can see that he's working very hard to work out how to stop sharing. I'll see whether I can do it. There you go, I did. So now I'll invite Andrew Henderson.
Thanks, Jason, and thanks, Professor Lavigne. We'd like to try and see if we can find Gunnar Kahlmeter and Jean Turnidge, who will be chairing the next presentation. So one of the benefits of doing this virtually is that if you're not in Brisbane at the moment, then you're missing a fantastic thunderstorm. So Gunnar, hopefully you can hear us, and I've just added you in as a presenter, and we'll just see if John has logged in as well, and John will add you in as a presenter. Fantastic. Hi, John.
Hi, Andrew. Afternoon.
Good afternoon, John. It looks a lot sunnier where you are than where we are. And I believe, so Gunnar, I believe that you'll be presenting first, and then John, you'll be presenting second in this session. So we'll have two fantastic speakers, as Jason has mentioned. Both, I think, probably need a little bit of an introduction. But Gunnar is joining us from Växjö in Sweden. Gunnar is the head of the EUCAST Development Laboratory, previous estimated president, and previous EUCAST chairman, and John is the EUCAST secretary. So it's fantastic to have two very well-established and experts that can guide us through this new process that EUCAST has implemented. So I'll hand over to Gunnar first of all. And John, I believe you don't have any problems interrupting Gunnar from what I've heard from what Gunnar had told me. So if you need to, this goes to continue. Thank you.
Yeah, good morning, Andrew. Good morning, everyone. Can you hear me, Andrew?
We can, Gunnar, yep. And you should just share your slides now.
Yeah, I'll share my screen in a second. Good morning, Andrew. Good morning, everyone. Good morning, John. Yeah, I think John and I have a long tradition of interrupting each other, so that's not going to be a problem. I will now look for sharing the screen, and it will be this one. So my next question is, can you all see this? Andrew, can you see it?
No, we can see that fine. That's perfect.
Good. Right. So good morning, everyone. I know it's not morning in your settings, but it's certainly morning here. The light is just coming over the horizon. The two dogs are whining because they are wanting their food. So I hope they're not going to be too disruptive. I'm going to talk to you about, well, both of us are going to talk to you about EUCAST. And we understand that what you would really want to discuss with us is the changes in the interpretation of susceptibility testing. But let me just lead into this by telling you what the ongoing projects in EUCAST are and what you can expect on the other side of the of 2020. So a couple of new breakpoints will be in the new table. We will have revised breakpoints for phosphomycin oral and T-mucilin. We will have breakpoints on two species that weren't in there before, namely Bacillus and Achromobacter pseudoxoxydens. We're working on methods and breakpoints for Corynebacterium diphtheria, Vibrio species, Nocardia. And we're looking at new methods specifically for this diffusion of anaerobic bacteria. And we've limited that to the 5 big ones and the ones that will actually grow in 16 to 20 hours. Bacteroides, Prevotella, Fusobacterium necrophorum, Clostridium perfringens, and Cutibacterium acnes. And we will extend incubation of rapid AST from blood cultures to 16 to 20 hours. The limit today is 8 hours. We have some pilot testing that shows that maybe we can actually develop a breakpoint table for 16 to 20 hours as well. Right, so in 2019, EUCAST revised the definitions of SI and R. And with this revision, we emphasize that phenotypic susceptibility testing is quantitative, which is opposed to genotypic, mechanistic, and AST-based testing. AST-based expert rules testing, neither of those are quantitative, they're all either or. And the quantitative nature of phenotypic susceptibility testing offers a number of possibilities. Will you excuse me half a second? Silly dogs. Silly dogs.
The dogs that must be fed.
You're right, John.
We see the puppies. Somebody's asked.
That was the only way to stop them whining, was to give them the second half of their food.
Somebody
So
wants to see your retrievers. You better show them a picture at some time.
All right. So let's have a look at the old definition of intermediate. I'm sure you all know it, but the old definition was rather clunky. It was a microorganism is defined as intermediate by a level of antimicrobial agent activity associated with uncertain therapeutic effect. It implies that an infection due to the islip may be appropriately treated in body sites where the drugs are physiologically concentrated or when a high dose of drug can be used. It also indicates a buffer zone that should prevent small uncontrolled technical factors from causing major discrepancies in interpretations. And this is verbatim from not only the EUCAST documents, but also from basically verbatim from ISO. So it was an agreed definition with CLSI and via ISO. That definition is now changed. And the new definition reads susceptible increased exposure. It could have read increased dosing, but we wanted to make sure that we could encompass not only dosing, but also other means of getting the concentration, getting a higher concentration at the site of infection than just by dosing. So the new definition reads, a microorganism is categorized as susceptible increased exposure when there is a high likelihood of therapeutic success because exposure to the agent is increased either by adjusting the dosing regimen or by its concentration at the site of the infection. So it's pretty obvious from the coloring of the first definition that there were a number of different parts in the old definitions that are basically all gone except the increased exposure, which was in the old definition, but sort of was drowned out by all the other paraphernalia. So the old I was a mix of 3 different parts. And by mixing these into one letter, it wasn't really possible to know which of the 3 definitions was valid when laboratories received an I in a report. And the consequence of that was that intermediate results were poorly understood and completely distrusted. Clinical colleagues avoided using agents reported as I, and some laboratories avoided reporting I by automatically converting them into R's. And even surveillance programs from bodies like the ECDC and WHO and what have you not, Sentry, etc., would lump together I and R under the title of non-susceptible. So it was pretty obvious that the old I was totally useless and could have been converted to an R had it not been for the buffer function of I, which a lot of colleagues loved because it meant that they didn't have to take it very seriously when the material was crap or, you know, they had a bad day or whatever. So we put a lot of work into this. We had a number of open consultations. 3 were directly related to the change in definition. Another 2 to 3 were related to the dosing options and the exposure options, etc., etc. And for anyone who's really interested and would like to sort of delve into this, I would recommend going to the EUCAST website and look up consultations, because all the old consultations are listed there. All the responses from people who wanted to have a response and the EUCAST comments to all the responses are still there. So you can look into this and find out exactly what went on when this was decided. So the decision was to keep the S, I, and R letters because in a poll, more than 80% of the people who were asked, and we asked people like, you know, the ESCMID executive, we asked CLSI, we asked EMA, we asked ECDC, we asked all colleagues that wanted to have an opinion, etc., etc. And more than 80% in those polls were in favor of keeping the letter because everyone realized what a mess we would have during a long period of time if we tried to change the letter. A lot of automated machines that would be on the old letters for a while before they managed to change their software, etc., etc. So it was decided to keep the SINR, but to change the definition and emphasize the quantitative aspect of phenotypic AST. But also to emphasize the relationship between the concentration of the antimicrobial agent at the site of the infection, that's what's called exposure in this definition, and the breakpoint for categorization of S, I, and R. Sorry for the disruption. Those were my croissants that just were just ready in the oven, so that was good. And then the consequence of that was that we needed to review all and revise relevant breakpoints to correspond to the new definitions. And then, of course, to task clinical laboratories to look over their AST methodology, make sure that they were doing things right, that they had good material. We looked into the disc quality, we looked into Muir-Hinton quality, and there are articles on the website and in the literature which look into all of that. So the new I, because S and R are basically what they always were. S, go ahead, use whatever your normal, your guidelines would encourage you to use, normal dosing, normal exposure, whatever, and R still means this will probably not work, leave it. But the new I is really related to the lower activity of the agent against a defined organism, either because the species is intrinsically less sensitive to the agent, and basically what this means is that the wild type is reported I. It's not sensitive enough to be reported S. It requires increased exposure already from the start. And the consequence of that is, of course, that only I and R are possible. And with the new terminology, this is how organisms would look. So you've got an I for susceptible increased exposure for this Pseudomonas aeruginosa against ciprofloxacin. It's the wild type is almost 10-fold less sensitive than an E. coli and 100-fold less sensitive than a Hemophilus influenza or a Neisseria. And then you have resistant. And the other alternative to the decreased sensitivity is because of low-level resistance mechanisms have reduced the sensitivity of the organism. And then, of course, the wild type will be S. You will have I's, where you have low-level resistance, which is not severe enough to cause failure, but which will require a higher dose, and then R for resistant again. And this is what that will look. So these are strep pneumo and benzyl penicillin. You've got two susceptible categories, S and I, and then you've got the level where therapy is not reasonable. So there are a number of means to significantly increase the exposure, and we think it's important to not only think about dosing, but to think about the other means of increasing exposure. So for beta-lactams, you can either increase the dose, you could increase the number of dosing, or rather decrease the dosing interval, or you can go from oral to IV or from IV injection to infusion. And there are a number of ways of gaining 1 or 2 or even 3 MIC concentrations. All of this you can find on the EUCAST website. There's a small menu to the right where you've got the breakpoint tables, and you've also got the dosing table as a separate document for printing. And just to draw your attention to the left-hand menu, where there is a possibility to read about what EUCAST thinks about what to do when there are no breakpoints at all, which is currently the case for Bacillus species, for example. Now this is the dosing tab, organized according to antibiotic group, standard dose, high dose, uncomplicated UTI, and then comments for special situations. This table is evolving. It's going to get more and more detailed, more and more thought through. But I would like to say that it's not a guideline for dosing. This is to tell you what the doses were that we had in mind when the various breakpoints were set, S, I, and R. So if you're dosing below these, you should probably think about either going through the rationale for your dosing, or maybe to use a different breakpoint in that case, because these are the doses that are sort of the minimum dosing for a valid breakpoint in EUCAST vernacular. And this is what causes all the discussions and all the problems for you, because you're so used to getting piperacillin S or piptazo S for Pseudomonas and ticarcillin and cefepime and what have you not. And it feels really awkward to have to report an I. We had a long discussion yesterday with all the national AST committees. And I think John would agree with me that the summary of all those discussions were that some of the national committees had really put effort into explaining to their clinical colleagues what all this is about, and had fully accepted that this is actually logical, it will work, it will take some time for everyone to grasp, but it will work. Just to point out that the S less than or equal to 0.001, which a lot of people think is a really silly breakpoint because it's not a breakpoint you could ever put into effect, which is exactly the reason for why we have it. We don't want anyone to put it into effect. It's to avoid anyone reporting S for ciprofloxacin and Pseudomonas aeruginosa, to take one example. And the corresponding arbitrary breakpoint on the disc diffusion is more than or equal to 50 millimeters, which again is a really ridiculous zone diameter. And the other problem, of course, is that this leaves a couple of S's, all of them perfectly logical from a dosing point of view. Meropenem vaborbactam, if you follow the dosing recommendations approved by FDA and EMA, 8 is what you get, whereas meropenem has never applied for a standard dose corresponding to that. So meropenem still has 2 over 8. But high dose meropenem corresponds exactly to standard dose Meropenem-Weber-Bactem, just to mention one example. Yes, so these are a variety of proposals for how to deal with the new I from colleagues. And actually yesterday with the 35 national AST committee representatives, the final recommendation from the group was that the EUCAST recommendation report as EUCAST recommends. And many of them also advocated to add a comment initially during the first year or two to explain what this is all about, and that it really means that the bug is still as susceptible as it once were, and that if you have read up on dosing for Pseudomonas or whatever, you can go ahead as normal. I think there are a number of good arguments against local adaptation or national solutions. One of them being that the old I lacked meaning and respect among colleagues, and I think a lot of you know that people would scoff at an I, and I think John will go into that later on. I don't think it's a good idea to mix a new system with remnants from an old system or breakpoints from other systems. It corrupts all of the new system and it corrupts all the other breakpoints, and eventually colleagues will be confused and different laboratories will be on different systems, and finally no one exactly knows which system they're on. I think it's better to work from within and try to influence the system, and the EUCAST system is possible to influence from within. I also think that although there are some stewardship issues with reporting meropenem S and ciprofloxacin I or ceftazidime I, it is possible to teach colleagues. It's not rocket science. And I also think that the agents we're talking about, with one exception, namely ciprofloxacin, are all hospital drugs. And other colleagues will not use IV agents. They will stick with what they know. And maybe in primary care, we should try to reduce the use of antibiotics in Pseudomonas aeruginosa, so-called infections, and the lack of an oral S may help towards that. And we agreed on this yesterday as well, that this will mean that clinical microbiologists and ID physicians and stewardship people will be asked more questions about what to do, and I think, and we think that's probably good. So thank you, and over to John.
Yes, we'll have to stop sharing the screen there, I think.
Yeah, absolutely.
Yep.
Stop share, there we go.
And I shall start sharing. Okay, and let's go to full screen. Okay, so I would continue with Gunnar's talk by trying to put it in the Australian perspective. And to make you realise how old this perspective is, I remember talking about I and reporting I at something called the College of Pathology Microbiology Update before it got swallowed into the whole meeting in 2001. I found my old slides and I've used one of them again to try and make the purpose, try and make the argument about what's going on here and what the landscape has been like in Australia in regards to I. I also at that meeting deliberately insulted my colleagues by calling them all patronising, and people still talk to me afterwards. So I must have said something right back then. So here are the, if you like, the traditional Australian lab approaches to I. If people have reported, they've just assumed it was intermediate. Some people used to think about it as indeterminate. And of course, many labs thought, I don't know, I don't care, I'm not reporting it. I find it irritating because those reading a report won't understand it. And of course, in the back of our minds, the labs thought, oh, okay, it could also mean increase the dose. More importantly, I'm sure all the lab people online would be aware that every lab makes its own decisions about how to test and report. There is no national standard. There's no national standard organisation that is willing to take this on. With other work I was doing, we attempted to get people to address methods like EUCAST versus CLSI versus CDS some years ago, but that ended up hitting a brick wall as well. So it's a matter of really just bringing everybody along with the knowledge about the new I and the decision that EUCAST has made. And for those of people who are in labs that use CLSI or are serviced by labs using CLSI, they need to know that CLSI has not made this decision. They do have a category that's somewhat equivalent to the new I in EUCAST, called susceptible dose dependent. That was considered as one of the options for reporting this new I in EUCAST. But then we just said to ourselves, but hang on, all categories are dose dependent. Susceptible, intermediate and resistant are all dose dependent. So it's a bit redundant to say something's dose dependent. And so after all that discussion, we moved to I. But those independent decisions are still sprinkled across Australia, and every lab has made another kind of decision. We're aware through Andrew's auspices and talking to Graham Nimmo that Pathology Queensland has never reported I and has basically just converted the result to R, which is probably one of the commonest decisions made in laboratories across Australia in the last 30 to 40 years. Of course, if they were working in labs that I was running, which was Monash Medical Centre and Women's and Children's in Adelaide, I was always reported, whether we were using CLSI or when we switched to EUCAST, it didn't matter. But of course, we all have this fear that the clinician sees the result and thinks, oh, I've never seen that letter before. And I would then turn around to that clinician saying, is your lab actually reporting strep pneumoniae? Because we've been using I for that species for years, no matter which system you use. The second, of course, is that I don't understand what it means. And of course, they're right. Traditionally, it had 3 separate meanings, none of which were explained on the report. And even if we did explain it on the report, how many of our clinicians actually read the comments? And so we know that many clinicians looked at the I and thought it stand for ignore and just hunted around until they found an S. But ultimately, with the good graces that Gunnar's explained to you about how we've come to this position of preserving the I, making it mean increased exposure and susceptible, is that we've eliminated all the extraneous meanings, and now I only includes one thing, only means one thing. And personally, I've been biased to reporting I before. I always find I informative, lets the clinician know that higher dosages actually makes the isolate susceptible, hence susceptible increased exposure. And Gunnar already explained those higher dosages. We're using dosages in a more general term of dosing regimen, which can be increasing the unit dose, increasing the dosing frequency, or increasing the infusion time, which is becoming more and more popular. We see with many of the new agents getting licensed, beta-lactam agents and beta-lactamase inhibitor combinations actually having prolonged infusion, which makes eminent sense from a pharmacodynamic point of view. I can be instructive. It allows the stewards to talk to the clinicians and provide the opportunity to promote better options. So scary though that Pseudomonas report might be that says IIIS, with the S only against meropenem, the stewardship staff can immediately point to clinicians saying, sorry, you're treating a Pseudomonas infection. it's actually okay to use any of those drugs labelled I, provided you give the usual Pseudomonas dose. And if you don't know it, look it up, or here it is there for you to know. And one important side effect is that it increases the percent susceptible in antibiograms, because there are two categories of susceptible. So when we're putting antibiograms and reporting susceptible, you need to add the S's and the I's in the EUCAST system. You can't do that in the CLSI system because their I still has that muddle of meanings. And it's of course increasing percent susceptible in antibiograms also helps stewardship teams to do their job. So here's a few ifs for you to think about. If we know that some bugs need higher doses, why haven't we traditionally signaled that to the clinician? I think we've always assumed that clinicians know that if you're treating Pseudomonas, the dose is kind of double. If the drug's given more frequently, at least for the beta-lactams. Nobody thinks of doubling the dose of aminoglycosides, but although they will give maximum doses. So having I gives you an opportunity to actually give the clinician extra information if you haven't been using it before. And if a lab is trying to work out how to introduce I, why don't you have a look at what other countries have done and what you can learn from them. And Gunnar has now actually put some countries that have actually gone down this path. The two shining examples from the EUCAST point of view are Germany and Norway. And there's some presentations on the EUCAST website which you could look at and see how they've addressed the problem. And finally, for those who are worried about the fact that I also included assay variation, the plus or minus 1 dilution in the MIC that people like to bang on about, EUCAST doesn't have to worry about that because the assay variation is actually included one step back in the breakpoint setting process by actually working out ECOFs, epidemiological cutoff values that describe the wild type and ensuring breakpoints don't move into the wild type. And all the assay variation is incorporated into the estimation and calculation of epidemiological cutoff values. So intra-laboratory assay and inter-laboratory assay and even inter-method assay variation are frequently all incorporated into the ECOF setting process. So, of course, there are some irritations with all of this. Not to live as, oh no, we've got more work to do. We thought susceptibility testing was sorted out. And we have a big enough headache because they're getting a new laboratory information system and da-da-da-da. Do we need this kind of irritation? But I would say that the investment of time is worth it. Gunnar has spoken about the choice of letter and it was subject to wide consultation and there was an overwhelming support to keep the letter I. That means you don't have to go around fiddling with the laboratory information system codes, and you don't have to change anything in your Vitek or your Microscan or your Phoenix or whatever. So that means that it's a little less painful from that point of view. But of course, it could still result in confusion given that I's had a bad reputation. And I've always felt that the labs that are reporting I have probably got a much more challenging task, convincing them I means something different now than the labs who previously haven't been reporting it. When just putting it on a report will actually throw up a question in people's minds about what that means, and they might actually read the comments. Pseudomonas, of course, we keep up bringing endlessly because it's the most common irritation expressed in every country and by all clinicians, that if we're following the logic of the eye, then all standard dosing are listed in dosages tab of the breakpoint tables that are inadequate for Pseudomonas, and it requires the high dosage regimens that are listed there, except for meropenem. I know people are tackling this in different ways. I know some labs in Australia, there's a couple of labs in Australia that have introduced the new I in the EUCAST system. And I know one of them's chickened out and reports everything as S. That's okay, but ultimately you're going to have to explain why you changed things. So probably better to do it straight up and get it all over and done with, rather than to do it piecemeal. But again, you've got to know your clients and you've got to make the decisions that way. And one thing that probably annoys us more than it annoys you is that a lot of the breakpoint revisions, including revising breakpoints around the creation of a new susceptible increased exposure category, means going back and looking at all the older agents. And the thing that we're finding out, having been through the fluoroquinolones and the immunoglycosides in recent times, is that the PKPD studies are telling us just how many older agents we've been underdosing for decades. And you might come back to me and say, well, patients got better, didn't they? But then I will ask you, what measuring system do you know that your patients have been dosed adequately, have had adequate exposure? And did you actually monitor the morbidity and mortality of your dosage regimen? Of course, nobody has. So we think things are doing okay, but we don't actually know for sure because we don't have measuring in place. So we rely very much on getting the PKPD right. And I can tell you, when it came to the revision of the immunoglycoside breakpoints, it was giant heartache working out that you can't really give enough gentamicin to treat Pseudomonas, not without making it a much more toxic drug. So gentamicin had to take a back seat, and tobramycin is the anti-Pseudomonal for Australia, at least. We're not so fond of amikacin, we tend to keep that in reserve. The disadvantage to that is that somebody tells me that the recent revision of the VITEC guide has taken off tobramycin. Oops, I would say, oops. Go back to the old one. And of course, the one thing we did learn from this process is that sometimes it's not just adjusting breakpoints, but it's actually adjusting dosages. And we had to go with maximum dosing to justify any of the breakpoints that we listed for immunoglycoside. And finally, a big irritation for everybody has been Hemophilus influenzae, and I say everybody, including EUCAST, because the EUCAST has a big problem with our ability to separate wild type from non-wild type phenotypically. And Gunnar and Erika in the EUCAST development, they've bent over backwards playing with all variety of phenotypic tests to see if we can improve it. The problem being that you've got two major mechanisms of resistance operating, both fetal lactomases and altered penicillin binding proteins. And so there are 4 different varieties of Hemophilus influenzae, depending on whether they have none, 1 or 2 forms of resistance mechanism. The current table is probably as best as it's ever going to get. It's never going to perfectly separate these two, but with some tips and tricks and massaging over the years, I think I'm pretty close to figuring out what the right answers are. Just if you follow the algorithm that's on the Hemophilus tab, breakpoint tables. So I'm not sure, Gunnar, how many years of work that required, probably 4, 5. But it was I think, in the end worth it to deal with this problematic organism. CLSI has chosen not to tackle this organism yet, so they don't know how many headaches are ahead from their point of view, trying to untangle this problem. The other thing we did in examining this is the susceptibility to amoxicillin clavulanate requires maximum dosing. What I was certainly unaware of until the work was presented by Johan Muton is that absorption of amoxicillin is actually saturable. And the exposure you get with 1,000 milligrams is the same as that you get with 750 milligrams. And in order to get adequate exposure for Hemophilus influenzae, 40% free drug time above MIC, you need to give maximum doses. So suddenly amoxicillin and amoxicillin clavulanate are shifted into the I zone. And it's logical, but again, it does require explaining clinicians for reasonably common isolate. Just so you know, work done at Concord, recently published in JAC, just come out this month in quotes hard copy, is that they compared all the different systems for looking at resistance mechanisms and susceptibility in Hemophilus, and in particular compared EUCAST to CLSI and found that EUCAST was clearly superior. So finally, given that this is Queensland based, all I could say is Queensland, beautiful one day, increased exposure the next. It's been a state of early adopters, and we hope that you fit that category when it comes to I. Thank you very much.
Thank you to Gunnar and John, and to Prof. Lavigne. We've got one question that has been put into Q&A, and I'd encourage anyone that does have any questions now to put them in there. I'll hand over in just a second to Dr. Harris, who's the Acting Director of Pathology Queensland, to moderate this next part and to hopefully have a little bit of a discussion about what may happen moving forward. But if I could read that out. So the question was, can you offer advice for reporting, managing Pseudomonas infections with aminoglycosides, specifically with gentamicin? I'm inclined to report gentamicin should not be used as monotherapy. Combination therapy is required. Please discuss with micro. Can you comment on the higher dose of amikacin recommended and any safety data from this? We currently use 15 milligrams per kilogram.
Yeah, looks like Gunnar's gone off to get a cup of coffee, so I'll start. My suggestion, that's one way of handling it, to put a note saying should not be used as monotherapy. We were unclear even after extensive analysis and discussion about whether it could be used in combination therapy for Pseudomonas. All the data favour tobramycin and adequately dosed amikacin, and I see that dosage question has come up with amikacin as well. So my instinct is, if you want to continue to report gentamicin, I would say the simplest thing is just to put a R, and you've got to have a tobramycin result to go with it. And I think that's critically important. So it has to be looked at in terms of, do you have a tobramycin result available? Can you report that? If you haven't, maybe that issue needs to be addressed first. You want me to talk about the amikacin dose?
That would be great, thank you.
Yeah, look, we had a long discussion about that because it's quite popular in the UK. They have the tradition of using 15 milligrams per kilogram. Pharmacodynamics is extremely clear. That dose is inadequate, and probably always has been inadequate. And we actually need 30 milligrams per kilogram. You need double the dose. That amikacin is fourfold less active than tobramycin, gentamicin against gram negatives, and everything needs to be fourfold higher. 4 times 7 milligrams for Tobra and Gen is 28 milligrams, because the kinetics is not that much different. So yeah, I know it's painful, and the drug's not cheap either. So all of those issues play in. That's why I think it's still a reserve drug, but if you're going to use it properly, I'll say.
And just before I hand over to Patrick, I might just ask one question myself. So, John, I think we were talking about this before, but in Australia we use amoxicillin and hyaluronic acid twice a day rather than 3 times a day, which is recommended as a standard dose. And you sort of data there on Hemophilus as well. Should we be encouraging the 3 times a day administration of amoxicillin hyaluronic acid, or are we still sort of in our national guidelines able to support the twice a day dosing?
I can recall when the 875, 125 formulation was first developed. In fact, pharmacodynamics had bobbed up by that time, and it was clear that this is a time above MIC drug. And the company developing it were aware of it, and they actually looked at the time above MIC that you get with the twice daily dosing. And it was actually slightly less than what you see with traditional 3 times a day dosing 500. And they thought that was good enough to go, and so we've got used to that. It's certainly been my clinical practice if I've been treating anybody with a moderately serious infection. They've been getting 3 times a day, and I've been doing that for 20 years. So to me, the kinetics was we can't afford to get that wrong if we're going to use it properly. It's really a 3 times a day drug.
I think what saves us is that, you know, most Hemophilus infections are not actually Hemophilus infections, and Hemophilus is normally not a very aggressive bug. So our failures will completely drown out among all those situations where we feel that we succeeded, but which was more a question of immunologic systems in the patients and the fact that the Hemophilus we isolated from nasopharynx or whatever wasn't really very relevant. Can I just say about tobramycin and gentamicin? I think we've known from the 1970s, there is certainly literature all the way back to the mid-70s saying that tobramycin is more active than gentamicin on Pseudomonas, and that is probably the major difference when everything is said and done between gentamicin and tobramycin. And when John and I look at all the wild type distributions, it's pretty obvious that it's a 2-fold difference in MICs. And since the PKPD, all the PKPD speaks to a very narrow margin, that 2-fold difference, which wouldn't mean very much maybe with benzyl penicillin, but with an aminoglycoside, it means everything. So I think the only reason to ever use gentamicin for a Pseudomonas infection in my book would be that tobramycin wasn't available. And that is the case in some of the old East Bloc countries like Latvia. I don't think Croatia has tobramycin, and there are a few places around the world where tobramycin is not licensed. So that would make some sense not to use tobramycin because you can't get hold of it. But otherwise, I can see no reason except for tradition to want to continue to use gentamicin for tobramycin for Pseudomonas infections.
Hi, it's Patrick.
Hi, Patrick. Good to see you.
Hi, thanks so much for this stimulating discussion. As I'm sure you know, we've been wrestling with this problem quite a bit within PQ, and it's really helpful to sort of have your views sort of laid out so clearly. So look, I'll just keep going with, there's a few more questions here in the Q&A. I'll read this out for everybody. So from an anonymous attendee, I feel like I represent a middle ground in time between previous dichotomous cutoffs based on traditional antimicrobial dosing and a future where therapeutic drug monitoring is more widely available and dosing can be tailored to an MIC and serum tissue drug concentration. Do you think I will remain as is or will eventually come to mean therapy with this agent is recommended to be accompanied by TDM to ensure adequate drug exposure? Is this question written by Jason or?
Does look Jason,
Yeah,
right?
it sounds like it could be Jason or possibly Paul Ambrose. Can I go first, John? and
Sure.
you can fill in. Yeah, I think that's fantastic. You know, one day we will be there, and everyone will be performing MIC determination, or you know, whatever we have reached methodologically by that time, and we will all have small pocket calculators in our mobile phones and what have you not. But I don't think we're quite there yet, and I think a lot of us need to shape up on our acuity when it comes to MIC testing before we're there. So there are a number of things that need to happen before we get there. So I think for the foreseeable future, we're going to need to use SIs and Rs. I don't see them branching into, you know, 4 or 5 or 6 categories, but I think we're going to need at least the 3 categories. What I think we might look at in the future is perhaps a double R. So when it's really resistant, maybe we need a double R, because there are an increasing number of situations where an R is actually not an R. If we're willing to go way beyond the accepted dosing, we could perhaps tackle some of those infections. But for some agents, that is not going to work, like I think trimethoprim sulfamethoxazole. It may work for meropenem, it may work for a few other beta-lactams, it may work for a few agents, but I don't think it will work for all agents. So maybe we will need R and double R in the future, but we're not quite ready to do that yet. So the short answer is no, I don't think we're going down that road very quickly, although we may get there in the end, but it will take some time.
I can just add to that. I mean, the bulk of testing that labs do is there for community practice when you look at it on a worldwide scale or even a national scale. And we're not going to be doing TDM in many of those. But I mean, I think TDM is grossly underutilised in hospital practice. And if Jason, you wrote that question, then you know my answer already. And you know, Jason's already shown the value of going down this path in the intensive care setting. And I think there are many other parts of the hospital, no doubt. Royal Brizzy, for instance, where that must be happening anyway. So I think that's a good idea. The big caveat that so few people are aware of is that a single MIC measurement is actually a hazard. And a single MIC, the assay variation on a single measurement is quite significant. Everybody thinks of it as being one plus or minus 1-2-fold dilution, but that can have a very profound impact on a pharmacodynamic index and therefore any dose adjustment. And I call an MIC measurement a sample from an MIC distribution population. And so you actually have to think about it as a statistical result and put it in a range and make sure you take the range into account. The pity is that we don't actually have that information except about what the range is except for quality control strains. And we don't know whether that's fair to extrapolate to every known isolate. So I think there's that side of the equation about using TDM and MICs to replace everything that also needs to be addressed. And it's probably harder to address than the therapeutic drug monitoring, I would say. I'll leave it at that.
Can I add to that, John, just to say that we're getting that data that you're now asking for in clinical strains, and the variation on repeat testing is roughly the same as when we use quality control strains. It increases when we get to the really resistant strains, the strains with enzymes and what have you not. It decreases when you look at strains that are uncomplicated from the point of view that they do not produce resistance mechanisms. So plus minus 1 dilution is sort of the best we will ever achieve, and we have to accept that for a number of resistance mechanisms, it's actually plus minus 2 dilutions and sometimes even worse.
So there's a question here from Noelle. So those of you who don't know Noelle, she's our sort of susceptibility testing guru, obviously Queensland, and has again been sort of wrestling up with Hemophilus for a long time. So she's asking, for Hemophilus, would you suggest that labs stop reporting susceptibility on isolates from non-invasive disease? And I guess I should predicate this on the fact that I have to admit we have temporarily stopped reporting from non-sterile sites. We can do it on request. Interestingly, we've had almost nobody request.
Yeah.
Apart from blood cultures or CSF or anything like that. As you say earlier, I've always been a bit suspicious that there's an awful lot of Hemophilus that we just pick up through, as a fellow passenger, not necessarily causing the disease. And it's interesting that we've had so little requests when we stop reporting. But I'm not sure what that says, whether our clinicians are just not reading the reports or what's going on. We were finding that we were sort of pushing a lot of people to overuse things like ciprofloxacin or moxifloxacin. We thought was probably unnecessary, and spending a lot of time sort of agonising over this testing or doing lots of new tests that probably seemed to be unnecessary. So, interested in your thoughts on that.
If I can start, I think this can always be done in two steps. You can continue to test but stop reporting, and you can add a comment saying the result is available should it be needed or something like that. And as you say, for some bugs, we will then discover that the result is not needed once they get to think about it. So I think from a stewardship point, there's much more to be done by not reporting things than to discuss how we report things. So I would certainly advocate stop reporting Hemophilus influenza, and then following maybe a year or two, I would then consider stop testing, because there is some money to be saved, I suppose, by stop testing. But there are other bugs in the system where we could have the same discussion, I'm sure. Pseudomonas being one of them. Yeah, I think we're actually doing an awful lot of. Sorry, John.
Oh, I've got to add to that.
Sorry, John, were you going to say something?
No, I was going to say I had nothing to add. Gunnar's covered it nicely, thanks. Yeah.
Okay, so
we lost you, Patrick. I think you went to mute. Yeah.
So there's a question over here in the chat box from Andrea, I think, from MSD. How should pharmaceutical companies support appropriate dosing? Real-world evidence for a recently released antibiotic was high dose with high dose for pneumonia shows evidence of underdosing.
I think pharmaceutical companies are in a bit of a dilemma. They get a licensed dose and then they can't talk about anything else. So with the passage of time, we eventually get doses right, don't we, Patrick? But I would have thought that pharmaceutical companies themselves are in a bit of a bind, because if the licensed dose is less than what we now consider adequate, that's a challenge. If it so happens that they've licensed at a high dose for special situations, it's probably easier if we say, oh, well, that's the dose for everything now, to promote that. But I don't have a solution for them otherwise.
Can I add to that and just say there is another comment in the chat, in question and answers, about how the adequate dosing in the EUCAST dosing table was determined, and I think that sort of ties on to this. And we don't have the PKPD for everything, and of course PKPD has been a very important tool for the discussions on review and revision of aminoglycoside breakpoints and dosing, quinolone breakpoints and dosing, temacillin breakpoints and dosing, phosphomycin. etc., etc. So it's not just new drugs that have been evaluated by, let's say, modern tools, to put it briefly, but also some older drugs. What we have also done to determine what should be in the dosing table is that we've gone out to all the member countries, if you like, all the EUCAST user countries, with a dosing tab and said, look, guys, these are the doses that we have used when setting the breakpoints. These are the minimum doses that we think go together with S and I. And we now want you to check whether those minimum dosing actually tallies with your practice. And if it doesn't, you either have to come back and tell us so we can adjust breakpoints in accordance with dosing practices, because a lot of people have a different opinion than EUCAST about what dosing practices are, or you have to start a process whereby you convince your clinicians that they may have been dosing this agent in the wrong manner for many years. And that has happened. Both of those has happened. So, for example, in Croatia, a few dosing strategies have been changed, just to mention one place. And in the dosing tab, EUCAST has heeded some of those comments that we've had. So I think the dosing tab is sort of a mixture of, or a synthesis of PKPD-based dosing recommendations, or PKPD dosing, and let's say the traditions of countries. We initially thought that countries would have very different traditions when it comes to dosing, but we were surprised to see that most countries actually have exactly the same dosing regimens, with a few exceptions.
Right. Yeah, I understand the analysis of wild-type Pseudomonas MIC demonstrates less susceptibility to gentamicin. Can you highlight any literature demonstrating clinical failure? Colleagues, quotes, haven't seen it fail, quotes, and are reluctant to adopt these changes. And I guess this is actually a question that's certainly come up a lot with us. So when these changes were suggested, we put it out to sort of clinical consultation, and we certainly did have some feedback that, you know, I guess people are used to using gentamicin and believe it works, and needed some convincing of its lack of efficacy. So I think you covered it a little bit before, but it'd be good to expand on a little bit more if you could.
Well, I might start on that one, Patrick. This takes me back to CLSI days when we started discussions about whether the breakpoints for third generation cephalosporins are appropriate or not. Remember when they were 8? And all the pharmacodynamic data said they should be much lower, you know, 2 or 1 or whatever, maybe for ceftazidime. And I think for 4 or 5 years, the conversation rattled on at CLSI saying, show me the dead bodies. That people are failing when their MICs are above these new proposed breakpoints. The problem is that I tried to point out before, we don't actually have good monitoring systems. And to answer the specific question about gentamicin, and can I demonstrate clinical failure? We did try extremely hard to find that literature. In fact, there's an extraordinarily good review done by Mikhail Paul's group in Israel, looking at aminoglycoside monotherapy. It's not that old, so it covers all the historical literature that's available. And the number of monotherapy drugs studies where we could actually assess the efficacy of gentamicin are so low, and the numbers are so low, and the number of Pseudomonas must be a subset of that, wasn't even counted and reported in the publication. It's in Clinical Microbiology and Infection. We weren't able to answer the question. And of course, how often do we use these drugs alone? Hardly ever. Does gentamicin help a little bit when you add it to piperacillin and tazobactam, or you add it to ceftazidime against Pseudomonas? I don't know. The literature doesn't answer the question. Those studies haven't been done unless you go to the original mousefly model in 1982, where Bill Craig actually started on pharmacodynamics before he even had the word, where he was dosing mice with ticicillin and gentamicin and showing efficacy, but those were mouse doses, and they weren't originally designed to look at what the exposures would be like in humans. So unfortunately, I can't point to literature saying demonstrating clinical failure, and I can't point to literature demonstrating clinical success. So we're kind of left in that kind of clinical limbo, and with these old drugs we often are. And I would love to be able to help answer that question, but does anybody want to do the study, or you just want to use the better drug?
Yeah, and I think when you compare tobramycin and gentamicin, they are, as far as I can see, they are completely alike in all other aspects, basically, except that tobramycin gains you decidedly gains you 2 MIC steps in activity. I can see no reason. Sorry.
For Pseudomonas, yeah.
Yeah, for Pseudomonas, yeah. So I can see no reason not to use tobramycin for Pseudomonas, provided it's available.
So next one, will EUCAST in the future have dosing required for different sites, i.e. bone, etc.?
So I'll start out on this one. I think the field to keep an eye out for is the comments field. I don't think we'll have columns for other infections than possibly UTI in the future, but we will possibly have comments in the comments field about you have to take care when treating this and that type of infection, blah, blah, blah. And I think you have to remember that the dosing tab in the EUCAST table is not a dosing recommendation. It's a minimum dose to go with the S breakpoint and the I breakpoint. I've had Swedish colleagues say, we never give as little as that. So what sort of crap is this? And the answer is, of course, you can give more, we don't really care, but you have to make sure that if you give less than what is in that table, that you have some good background data to support your dosing, because as far as we can see, the dosing that is in that table is sort of the minimum level to make the breakpoints work. And then, of course, you know, treating meningitis on day 1 is different from treating it on day 3. And treating a knee infection in one patient is different from another patient, etc., etc. So I don't think the dosing tab or the EUCAST guideline should be worked into a therapeutic guideline. We should stick to what we know best, and that is the pharmacokinetics, the pharmacodynamics, and the science behind the breakpoints.
There's no more typed questions, but I might chuck in a couple of my own if you don't mind, but I won't keep everyone too much longer. I was interested about I saw in your slides that Japan had rejected EUCAST and gone back to CLSIs. Did I read that correctly? What was the story behind that?
No, it's, you know, some colleagues are very irritated with EUCAST because it sort of upsets their everyday work and they have to stop and think about things, and that's irritating. I know how irritating it is, so I sympathize with them. But of course, then sometimes people let slip things like, you know, if this is the way EUCAST is going, we might as well abandon EUCAST and go back to CLSI. And I just wanted to point out that as far as I can see, there are 2 choices. You can either start your own breakpoint committee. Actually, 3 choices. You can either start your own breakpoint committee. A lot of work, I can tell you. You can go with the Japanese, or you can go with CLSI. Those are the 3 options. If you go with the CLSI, you will be roughly 50% divergent from FDA, if you think that is any measuring tape.
And what have been the experiences when you mentioned places like Germany and Norway that have adopted this approach wholeheartedly. I get the impression that that ultimately has worked reasonably well. How would you sort of characterise that, or might be too optimistic?
You start, John.
Yeah, I'd say that well, we have representatives on the steering committee from those two, and they were responsible for organising the national education effort. You can imagine that in Germany it's 50 times bigger than Norway, population-wise. So they had Sarah and Gutterman on our committee spoke to that again last night, and they organised a large number of meetings, had a lot of discussions. There's always going to be a small number of disgruntled people. They communicate with EUCAST anyway, and we deal with their issues one by one. I'd say, given that Germany's like Australia, all of these labs are making their independent decisions, that's been a pretty significant move. Norway, smaller country, everybody knows everybody, rather easier to organise, and used to the Scandinavian approach of everybody sitting around the table and agreeing how to do something. Another country in that category is Slovenia. There's not a presentation from that. Slovenia is even smaller than Norway population-wise, but entirely cohesive in terms of they all sit around the table and decide whether something's good, bad, or indifferent, and all do the same thing. So I don't recall any negativity other than saying, oh, Dr. X from Bonn, he's a bit irritating, but we deal with him. And in fact, Dr. X from Bonn emails us regularly anyway, so and we all deal with him.
It's actually Hamburg, isn't it?
No, it is Bonn, I think.
Is it? Okay.
Yeah.
Anyway, can I just add to that? Can I just add to that, John, to say that I think the gist from all of them is that those that have now succeeded and are happy with the result all had to put in quite a bit of work to discuss this with their colleagues, to inform, to think about